feel free to jump in, but it was a really neat anatomical variations. So in this group, they looked at about 20 patients, human patients, about what their fascicles actually look like anatomically, the variations. And so in the first type, this is type 1 of the type, there's 3 different kind of subgroups of this, where each of the left septal fascicle has a kind of has its own origin, either to the trunk of the left bundle, to the left anterior fascicle, or even to the left posterior fascicle. So, and then there's this type 2 where the left septal fascicle will branch out from both the anterior and the posterior fascicles. And then there's this another one, which is like a fan-like interconnecting network where it's just kind of all over the place. So these are, I guess, probably the nicest ones to have. You know, you kind of put your lead anywhere and probably get something nice. But just, I mean, there's so much variation. I think that, you know, a lot of the times, or not, I don't know, but a lot of the times, but most of the time, getting a nice implant is sometimes luck, right? So, and maybe just because of the underlying variation in it. Yeah, So I wanted to also talk about current of injury, because it's a great article that came out of this Chinese group last month or two. And so it's really looking at the current of injury to know, you know, what you should do with your lead. Should you keep it where it is, or maybe take it out and find a new position? So really the current of injury is ST segment elevation from baseline because of trauma or focal tissue where the helix is advanced through the septum. So the relationship between the current of injury and the lead depth has not really been well established. And so this group did a observational study. They looked at about 212 patients, which translated into 450 or 500 kind of lead implants. And they analyzed those to see whether current of injury was actually useful to see where they were or see if they actually perforated. So here, they're just giving kind of a baseline example. This is the intracardiac EGM here, which we're used to seeing. And this is the current of injury EGM, which is essentially the analyzer. And you can see the bandpass filters for each of them. So this one, the bandpass filter has to be very, very wide to be able to see that current of injury. So this is an intrinsic beat here that we're seeing. And this is the tip. And you can see this very nice current of injury present, and this is the ring, still nice current of injury present, but just significantly lower. This lead is actually placed at the left bundle. We know there's a left bundle potential here, with a left bundle potential to surface QRS of about 28 milliseconds and an LVAD of 72 milliseconds. So here they have selective pacing. We know that because there's a discrete component that's present on the EGM, on the left bundle pacing EGM. And again, a nice current of injury. And here's non-selective. And the current of injury is still very nice. Now, this little fractionation here doesn't really represent, it doesn't really correlate to the left bundle potential. It doesn't correlate to LVAD. It doesn't really correlate. So this is just really injury. I think. And sometimes if you have a right bundle branch block, which we'll see in the next case, you can kind of see this a little bit more prominently. So in these patients, in the 212 patients that they did, there is a distinct unipolar current of injury in 92% of them, and the average tip was about 10.6 volts. The leads with lower left bundle branch threshold, so lower than 1 volt, displayed greater current of injury. So the better current injury you have, I think the better the implant will be. In fact, even where I decide where to actually implant my lead, I just see what the R wave looks like in that current of injury. And if it looks good, it's probably good tissue. It's probably not scarred tissue. And interestingly, patients without an initial tip current of injury, so really not this nice current of injury here, they had usually microperforation or actual obvious perforation. So they had a sensitivity and specificity of 195%.
So how do you decide you have microperforation?
So
I mean,
that's,
you're just making this up, I think.
Well, so, okay, so let's keep going. It's a good question, you know, like I think, and I think we have, Vartan has a really nice case later on, so we'll have more discussion on it. Because microperforation, I think, is probably the hardest to really diagnose. Here in all their 11 cases of clear perforation, microperforation and and clear through and through perforation that was diagnosed on echo. You can see that the impedance doesn't, I mean, it's low-ish, but it's not terrible. It's not like 300 or, even lower. They always say something like impedance of 400 or lower. It's probably suggestive that you're probably perforated. But here it's, it's not very helpful. Whereas when you look at the current of injury of the tip at the place where you are, if it's super low, then that's more correlating with somebody who's probably perfed. When you look at the ring, the ring here, these must be perforated through and through because the ring current of injury is almost nothing. Whereas here, the ring is not, the current of injury at the ring is substantial. So it's probably within the septum, whereas the tip is not. So this is probably, at least the tip is through, but the ring is not. And then, so then they created this tip over ring kind of ratio here. They have this idea of, if you're, you implant your lead, you then do unipolar threshold testing. And if your threshold is high, i.e. over 1.5 volts, and if you don't have a current of injury, pretty well this patient has a, they essentially say that you should reposition the lead because there's likely a microperforation if the threshold continues to increase. If you still have a current of injury that's present, then they say wait a little bit longer. If the current of injury is still present, then maybe you should do something else like advance the lead a little bit more, wait a little bit longer, or if there's really no improvement, then you reposition, although waiting this long is probably not really practical. And then if you wait 10 minutes and then you don't have any current of injury, then it's probably that you should reposition the lead, because most of the time that is the case where the capture threshold remains high.
Jackie,
and this, yeah, go for it.
can I ask a question?
Yeah, go for it.
There's a couple of papers also looking at both the impedance and the current of injury in unipolar. That's what I do now when I do my implants, because if you think about it, if you're still in unipolar and your helix is getting a little bit outside of the endocardium, the helix will see a current of injury that's going to start to be biphasic. You're going to have an S wave instead of a full ST elevation current of injury, and your impedance will start to decrease. And the rough number is around 500. So what I do now when I do the implant is that I just put my lead on the septum. I think I'm okay. I do a couple of turns so it's not going to move. I look for my W pattern in V1. And if it's fine, I start to screw. And when it starts to be narrow, but sometimes you will not have your RSR prime, because sometimes you screw too much because you really want the R prime, and you're going to perf to get the R prime.
Right.
So when it starts to be kind of a nice QRS, the axis is okay. I look at the current of injury. It should be really positive, sometimes 30, 40 millimeters.
Yeah.
And the impedance will be above 500. Now I know that I can screw more. So I screw a little bit more. And when it starts to drop, the impedance starts to drop. Often the current of injury will also start to drop a little bit, but it still stays positive. I think that's the clue. And when you have your micro perf, your current of injury will start to get an S wave. If you're completely perf with the helix, your current of injury will be a QS.
Exactly.
And the impedance will be lower than 500. That's what I use now to know if I need to screw deeper or not. Because sometimes, you really want the R prime in V1, but in some patients, you're not going to get it. It's going to be a little R prime, not that, important, but still a very narrow QRS, a very fine LVAT. But do you screw more? You can look at contrast, fulcrum sign, but I think current of injury needs to stay positive and impedance about 500. And it's interesting, there's a couple of papers where with the learning curves, they have more success at LBB, selective or non-selective, but kind of a nice result. But the rate of perf increases. And in some papers, it goes as high as 15, 19% of the time, because you really want that R prime in V1. And when to stop That's the problem.
Well, also, Francois, I mean, I don't, probably everybody else has had this as well. We used to start just doing, you know, one screw, two more screws, and then seeing and looking, what's the impedance? Is it rising appropriately? What's it? Now I just kind of screw, I find a good spot and I just go and screw, and then I go until I see the template beats of screw beats, and then I stop, and then I decide, you know, what to go, whether to go further. But usually when you see those nice narrow template beats, I just stop. So I don't even, it's almost like I've already gone far enough. And so then I look after at my current of injury and I say, well, have I perforated? Have I not? What's my impedance? It's almost like so maybe that's why we're seeing more perforations as well. We're getting a little bit more aggressive maybe early on when we're screwing, but
I think it's faster when you really combine morphology in V1, your LVAT in V6, and current of injury impedance. And you go boom, 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 boom until you get your V1 that you like. You cross-check with current of injury, impedance, and you decide if you have enough. If I think I'm probably okay, then I will look at the fulcrum and do a little contrast to make sure I'm deep enough in the septum. But certainly, we certainly perf more often, you know, searching for the best QRS. It's not a big deal. You unscrew, you start again, and you know, most of the time, it doesn't create any problem, even if there's some coronary venous fistulas described now. There's coronary artery fistulas described now with LBB pacing, but most often it's not a big deal. But I think we can prevent that by combining EKG morphology, current of injury, and impedance.
Yeah.
Just for the final couple of screws that you say, am I going to give a little bonus or not? And sometime I screwed up when I do a couple of bonus turn.
Yeah, no, you see that QS is really fun. It's really terrible. So great. Michael, are you on or no?
Hi, yeah, I'm on.
Yeah. Oh, fantastic. Okay, wonderful. Okay, welcome, Michael. I don't know if you wanted to have a quick, just present your case. It's a really quite quick case, but essentially looking at this current of injury here, which I thought was appropriate after this article. So what does this represent essentially? I think that's the question. Go ahead, Michael, if you have.
Sure. So this was a patient in whom we put in or we tried to put in a dual chamber left bundle area pacing lead. So this was her pre-op ECG, and her indication was a medical need for beta blockers, some intermittent AV block, and some sinus node dysfunction as well. And then if you go to the next, these were just some measurements at baseline before we started. Interestingly, through the case, so our first position, it was just one of those cases where Dr. Renee had told me don't turn forever, but I didn't listen and I turned forever and didn't get a good result. And then so I went down, and the next position, by the time I got to the next position, I noticed that at some point I had caused her to get a new native right bundle branch block. I had a separate question, which was, you know, does this get logged as like how important of a complication is this, or is this just like a thing that happens? Anyway, and then if you go to the next one, yeah, so we ended up getting another position that I thought was really favorable. The LVAT was stable. It was, I think, 72 and 76 milliseconds. The QRS was nice and narrow. I got an R prime that was very, very tiny, but again, I don't know how much of that was because of her right bundle. But what was interesting to me is when I saw this on the analyzer, this is unipolar, the LV lead after I'd screwed into what I thought was reasonable position. At first, when I saw that little potential, I thought, oh, maybe that's a left bundle potential, except it doesn't really match up very well with lead to the surface. This is on the Medtronic analyzer. Unfortunately, in our lab, I can't kind of project that up on the screen, so I had to take somebody to take a picture of it. But I wasn't sure exactly where that little marking is on the A channel, which is connected to the V lead, and it marks with the AS. I'm not sure if anybody's seen that before. I had another case where I had shown Dr. Joza that it looked like it was within the EGM on another case when we were into his position.
I think
I'll
one
just tell you
interesting
we
point.
have an analyzer where it's always way out. It's a software analyzer problem. That's not where, because I have patients where I'm clearly pacing the hiss, and yet, you know, so this is just that's not really where it's sensing. The two
So
line up.
yeah, so that's what I had wondered, because on that other patient where I was very clearly pacing the hiss, the HV interval using the surface on the analyzer was way off, but the HV using the EGM was more congruent.
I assume other people, you know, we just have, I don't know, a couple of our analyzers that just doesn't make any sense.
So then I guess my question is, if I ignore the timing between the surface and the EGM here, could this be a left bundle potential? Because that's what I had initially wondered and was hoping. But
You know,
Usually the filters are not quite a step to get on the analyzer a hiss or LBB potential. What I observed a lot of times is you have a huge injury current, but you have this small kind of QRS at the beginning. And what you see 10, 15 minutes later is that your current of injury is gone, but your real sensing is the first part of what you see there. So you end up with the current of injury of 30, 40, and your R wave 10 minutes later is 5 in unipolar, because all the injury current is gone, and your real QRS is the first part of what you see on the screen there. And sometimes you kind of worry because you say, okay, now I'm sensing 5, and I have the current of injury of 30 or 40. But you don't care if it's still positive and you don't have an S wave and your impedance is above 500 or close to 500. Most of the time when you're going to hook up the device, you're going to have a quite nice sensing of 8, 9, 10. But that's and in a lot of the manuscripts that are published, that's what actually they describe also, is the first part of that blip there is your final R wave. And the rest is just the injury current.
Yeah, no left bundle potential. That's a QRS.
yeah, that would make sense.
Cool.
Yeah, these were the LVATs for that patient, and I think I sent over her final. Yeah, this was, I don't know, I'm not, this was half made up. I think I was trying to look for that R prime in V1 and see if the delay between left and right was long enough. And then I think I sent you the final ECG. Yeah, so this was her final ECG. Interestingly, I'm not sure, they did it without me there, so I'm not sure if I narrowed up the AV delay to avoid fusion enough, but she's got a native beat in between. So I thought it was a reasonable result if I hope that I haven't fused too much.
It's beautiful. It's great. Thanks, Michael. Fantastic. So Vartan, are you around? So maybe I'll just get you to present these cases. And of course, please, everybody join in any discussion. I think it's super helpful and fun.
So I wanted to, by the way, before I start, I want to thank Jackie for doing these webinars, because the last time we hadn't started doing, and thanks to the webinars and help from Jackie, Atul, Dr. Paredes, Fadi Mansour helped us to get it started. So we started about 6 months ago. We've done a fair amount of cases. I want to illustrate a few little things by showing ECGs. The first thing is that looking at the baseline ECG of the patient before doing the case. I think that knowing the baseline ECG of the patient can predict like how the case is going to go and what to expect for your LVAT, what to expect for your QRS complexes at the end, so that you don't like try too hard sometimes to get a result that you may not be able to get. So I'm going to show like the first 6 or 7 cases. I'm going to show the pre and post, and showing that if you have a left bundle branch block as the initial ECG at baseline, like these were all cases with patients who came in with left bundle branch block, syncope, intermittent AV block, and EFs between, let's say, 40 and 60, for example. And the ones who have the Strauss criteria with like a nice double notch in AVL or V6, but here, for example, you see an AVL, QRS like between 140 and 160, you can get some of the narrowest QRSs after the left bundle branch area pacing. And often you get a fusion on top of it and you get like very narrow QRS. Like for example, if we go to the next slide of this case, this is one of the first ones I started. I had done it with the Biotronic lead, and you get the fusion between the left bundle. This is like more like fascicle lower part of the septum that was being paced, low basal part, and you get fairly narrow QRS. So if you have an ECG at the baseline with the Strauss criteria looking nice like that, you can expect an ECG like this at the end. Okay, next. This is another case like QRS about 140, syncope, low EF around 40. And go next. You get like narrower QRS. Next. This was done by my colleague in long PR, left bundle branch block. There's like a double peak here in the AVL. Go next. Again, you get like fairly narrow QRS. Here, there's no R prime. I'm going to get back to the R prime issue, but I find like if there's an R prime or like an R in V2 already, there might be a reason why it's not present there. I'm going to talk about it after. There's another case, nice double peak here. Go next. This one was done by my colleague. Then get fairly narrow QRS. Next. Again, double peak here. You got the nice Strauss criteria. Go next. You get like fairly narrow QRS at the end. At the end, I'm going to show some that don't have the Strauss criteria and what type of ECGs come out at the end also. Go next. Okay, there's a post-TAVI that got left bundle branch block, again at the double peak. Go next. One thing else I wanted to illustrate in this particular case was that the QR was only present in V2. And I heard this from other colleagues that were seeing that too. So if you don't see it in V1, I think looking at V2 is very useful. Because sometimes if you see a rapid transition in V2 or you see a QR in V2, you might be okay. Like in this case, I don't know, like Dr. Philippon was saying, do you do another 1 or 2 turns? And trying to get smart to do another 1 or 2 turns, and then you're going to perforate. When we see like it's nice and monophasic and AVL, there's a QR here, LVAT is very short, we stopped. And the result looks pretty decent.
And you have a small R prime in V1. It's not bad.
Very tiny, very tiny.
Very tiny, but it's there. And your axis in 2 and 3, a little bit discordant, a little bit positive in 2, negative in AVF. So you're not too low on the septum.
Yeah.
And you're not too anterior because you're not positive in 2 and 3. So it's a nice result.
Generally, I was going to mention at the beginning, we aim for mid-septum, but if you can't get mid-septum because of the anatomy of the patient or because of the sheath and stuff, the next spot is to go kind of lowish septum. That's what we're trying. So meaning lead 3, we're trying to get negative, and then 2, you're trying to get positive or biphasic, something like that most of the time. We work with the 6 lead when we're working. You go next.
Merdad, you wanted to say something?
I was just gonna, these are beautiful cases, by the way, Vartan. Is the question I wanted to ask was that with these left bundle ones, how many of these cases did you guys end up with complete heart block when there is nothing?
Oh, yeah.
I've had 2 cases that this happened, and I'm like, I didn't think about it beforehand. I'm like, putting in the atrial lead into the ventricle to get some capture while I'm trying to, screw in the lead.
Actually, the first one, the first one and this one, actually, I'm going to, can you go back, Jackie?
Yeah, sure. All the way back, yeah.
No, hold on. Yeah, the first case at the end, this was like this because the patient went into complete heart block when I was manipulating. At follow-up after, there was like fusion between the two. But now when I do a case that has left bundle branch block baseline, I always put the atrial lead in first because the manipulation it's going to happen. And you, instead of sweating it, you have it on connected already. You just pace while you're doing that. It's, I would say maybe 20% of the cases you're going to get it, something like a 15-20% transient. And sometimes it's going to make you sweat. So if the atrial lead is already there, there's also another advantage of having the atrial lead there. You see where's the tricuspid annulus, the bottom part of the tricuspid annulus. You know the anatomy very well when you're going in LAO and RAO, so it's very helpful. When I have a case of complete heart block or baseline left bundle branch block, I always put the atrial lead into the RV first and then start the case. It's
do you slit the sheath? When do you slit the sheath then in those cases?
Yeah, I slit it. Yeah, same thing. I slit the sheet with because you never know what's going to happen when you're slitting too. I slit the sheet,
Exactly.
secure the lead, make sure everything is very good, everything is all good, and then once I know that's there, then I pull back the atrium to the atrium and position it.
Yep. Yeah.
Yeah.
Some people say do it the other way, but I think that that's probably the safest.
Yeah, I mean, to be honest, with the Medtronic system, we didn't have any issues slitting, but with the Biotronic one, because you have less length, you sweat a little bit more when you're slitting it because you have so one time on one of my first cases with the Biotronic, I dislodged the lead when I was slitting, but with the Medtronic, it hasn't happened yet. Okay, go next.
Is that the one or no?
There was another one too. I'm gonna show, and it's the other case after one. I'm gonna show it's a combination. Go next. So this is the post-TAVI one that did the QR into. Okay, go next. Next. This one too went into complete heart block when we were positioning, and you see like this is what you get after, and then at follow-up is fusion. Okay, go next. Okay, so this is a case of a patient who came in with syncope, right bundle branch block, left anterior hemi block, very long PR, and we decided to go with left bundle branch area pacing. His EF is about 50%. And what I wanted to show is that when you're having baseline right bundle branch block, I still look at similar kind of things. I looked at the AVL, looks quite narrow. So we're thinking we should get a fairly like narrow result also in this case. Go next. So here, like a very small R prime, but in V4 and V5, we're getting like very narrow QRS. So we decided not to go any further. And in AVL too, it was looking decent. So we kept it like this. And if you go to the previous, it almost looks like this narrower than his baseline, even though it's a right bundle, the baseline is almost a bit narrower than it. So, and also the activation sequence is different. Even though we say we're pacing the left bundle, it's obviously not exactly the same thing as having a native right bundle branch block. Okay, go next. This one too is a native right bundle branch block, intermittent second degree AV block, and so on. Again, okay, we positioned, yeah, exactly, we positioned it here. Again, okay, here, very small R prime, LVAT about 75, 80 milliseconds. My question for Dr. Philippon, Dr. Paredes, Dr. Rene, Joza, all these people who've done tons of cases, would you advance this one further based on the ECG? Or you would have left it like this? It was a single deployment, one deployment. I went in, I saw this, I'm like, I stopped. This is where I stopped for this patient, but could we go a bit more?
And this is
Are
the
you
big.
I would look at
Are you a bit
injury current
apical on
and
that?
impedance.
Is my question is whether you're kind of apical with.
I'm gonna show
time
the
to get
image
an
of
R
this
wave.
case after. I'm gonna show. It was like very mid-septal actually. It was mid actually location.
Yeah, lead two is a little bit positive, so you're not
Yeah.
that low.
Yeah.
But I would look at injury current and impedance now and if I'm not convinced, I would inject and look at the fulcrum sign to see if it's deep enough.
The anode was
it's
not
not
in. The anode was not in. But this guy's septum was not very thick. He had like a septum of like 8 millimeters. But for sure, the anode was not in. I knew that.
Because I had a couple of cases where the septum was not that thick, and I would do a couple of more turns, and I would be on the other side saying, well, I didn't screw that many times, but sometimes they have, depending how you enter the septum and how thick is the septum. But, I would, if impedance is fine, injury current is still positive, it's a nice result. I think the lead is stable. The fulcrum sign says that, I'm probably deep enough. I would probably stop, but I don't know what the other ones are.
I have a question.
Just wondering, what do people
see-
think of the cues out to V4? It's a bit odd. I don't see that very often. I'm not entirely sure. That's why I was wondering if the lead was mid-septal, but more apical than.
Jackie, we'll show the CT after, but the question I want to ask is, if you're seeing a persistent small double peak in AVL, is it for you a sign that you could go a little bit further? Because I find the ones that you really come to the LV endocardium, AVL is monophasic. So if it's remaining a little biphasic, is there some room to go more? Dr. Paredes?
Yes, I mean, it depends on what you are working for. if you are working just for a almost normal ejection fraction, that's more than reasonable. And instead of getting more trouble, I will just stop there. If you're working for a patient with 25% ejection fraction, maybe you need to have an LVAT as close, I mean, as short as possible. And if you have 60, well, that's better than 80. So it depends for what you're working for.
This patient's EF was between 50 and 60%.
So
I knew the anode wasn't in, but because the septum wasn't very thick, I left it like this. Then the patient had a CT for another reason. Can you go on the next slide? I need to show all the clips of the CT, but I just showed an illustrative thing. This is artifact over here, but it was in, the anode is not in, but it was in about halfway into the septum, or maybe 3/4 of the way. It could have gone in a couple of more millimeters probably, based on what I saw on the CT. I mean, to answer Dr. Rene, I don't think it's really apical. I mean, I think it's mid. It was like,
I would say, I mean, it's more than halfway.
yeah.
I don't know. I'm not trying to be,
Yeah.
looks, there's the apex and there's the septum. It's 2/3 of the way down, I would say.
Yeah, I don't know if anybody is going to show something about being too basal, but I have a case. I didn't put it here, but being too basal is sometimes problematic too, because you get the tricuspid septal leaflet and other stuff. And I mean, it could have been maybe a centimeter more basal, but
Yeah, I'm not saying I mean, it's a nice result. I just was, the ECG is a little bit, I mean, it does, you know, if you were endocardial pacing on the right, you'd say that's pretty close to the apex, you know.
yeah. But for sure, that looking at our progression tells you how basal you are. If you see a rapid transition, you know you're more basal also. It's useful to look at that. Okay, we'll go to case 10. Okay, so this is a patient who has like a non-specific intraventricular conduction delay, and even look as baseline V6. He had a combination of sinus node dysfunction, syncope, prolonged QRS, EF about 50%. He has had a previous MI, and he has like a lateral scar. EF is about 50. Now this one doesn't have the typical Strauss criteria, and I knew going in that I'm not going to have a great LVAT. I don't know if people agree with that, but going in, like when you see a V5 and V6 like this of the baseline of the patient, I was thinking if I can get the same thing as what the patient has, that's the best probably I can hope for. And I said, there's no way I'm going to get LVAT 80, 90 in this kind of case.
Are you guys measuring LVATs in the EP lab?
Yeah, in the lab would spike the same, spike to peak in V6, yeah.
Well, the only reason I ask is that we can't do that in all of our EP labs, you know, depending on where you're booking these cases. I just wanted to see if anybody else has the
I
same
don't do it in an
statistic.
EP lab. It's just equivalent. I use the census vibe. It's used as they're doing cats there. And then if I have to do a case, I come in. I'll show you. I have a thing with a setup. I do a 6 lead, and you can go on 2,500 milliseconds and you can do all the measurements. It's like a CatLab setup, actually. The room is like a CatLab setup, but you can do all the measurements.
That would be nice to see. Yeah.
Yeah.
We have the same problem when we do cases in the hybrid suite for extraction, and you're all scrubbed, the chest is scrubbed, so your V1 is a little bit far from the sternum, and you don't have all your leads, and we kind of tweak the anesthesiology monitor, and we measure from there. But it's not as easy as in the EP lab, but it's manageable. But you don't want to do your first cases with that type of setup.
Yeah, I'm happy you talked about that. We're going to talk about the position of V1. Okay, so this is the ECG post-pacing. And this one was a very painful case. So I think I did, and the septum was thick too. I think I must have done 6 or 7 deployments. And then because you're not getting such a great ECG, I think 2 or 3 went through to the left side, came back. And then at the end, I was like, okay, I'm not going to get an R prime. I'm probably going to get something like this. This is the best result we could get. LVAT, 110 milliseconds, 110, almost 120. But I mean, if I look at V3 and V4, I know I'm close to the left-sided endocardial surface. You're not going to get an ECG like this without being close to the left side. So we kept it like this. I mean, the other question is like, when you get this, are you going to go to like a lot CRT and put a CRT in and stuff? But the guy's EF was 50%. I think there's no point to do that. And this guy had a random CT after for another reason too. Jackie, can you go to the next slide? I mean, it's really to the endocardial surface. I think you couldn't have gone more than that, but probably he has some disease of his ventricle and endocardial surface that to get to the left side is taking longer. And no matter what you do, you're not going to get a narrow QRS in these cases. And
Can
I
you
think
show us the
his EF
baseline ECG for that case, for this one?
Yeah, there it is.
Interesting, the Q in
Yeah.
in the lateral procurial leads.
Yeah.
Wasn't sure where that comes from.
He has a previous MI. He's had a previous lateral MI. He has an occluded OM, and his EF was about 50.
And
But-
unipolar pacing from the tip did not make any difference in terms of higher output unipolar pacing from the tip of the.
It was unipolar. Everything is in unipolar. When I was testing, it's just that the final programming, here is bi, but it was the same.
Like the morphology didn't change afterwards in the
No,
day unit
no.
or whatever.
Yeah.
Okay.
I have actually another case with the non-specific intraventricular conduction delay. It was the same thing. In the end, you can't get a really nice QRS if it's not a real left bundle branch block and it's because of ventricular disease, LV dilatation, amyloidosis, whatever, you don't get such a great result at the end. I think so. Point being, these 10 cases, I just wanted to say, like, I really look carefully at the baseline ECG before I start the case. And if I have time, I take a quick look at the echo too to see the septal thickness and stuff. So I know the information going in so that you don't get surprises and know what to expect. It shortens the case so that you don't get into trouble.
But I find those cases tough because the baseline ECG, does it really predict that it's going to be a hard case? I'm not sure.
Not necessarily for hard case, but how good of a narrow QRS you're going to expect. Because if you think that this case was going to get a narrow QRS, I think it was never gonna happen. I knew going in that I wasn't going to get a narrow QRS, but I still was being stubborn and trying to get a narrower LVAT and stuff. And all you're just doing is like shish kebab, being in and out of to the left ventricle, 2-3 times was like bad move. Like knowing it now, this is one of my earlier cases. Now I think I would have probably stopped if I had an ECG like this. I would have stopped. And also, like, there's other things, I don't know, like, you see, there's like a tiny bit of like Q at the beginning before it starts, almost like a latency in V3. I don't think you can get farther. You're like at the endocardial surface of the left side. Go next.
Yeah, I don't think you can get better. I think the muscle is the issue here, not
Yeah.
the conduction system.
I actually don't think your LVAT is that bad on those ones. I mean,
Oh, they're
this is
beautiful.
visually, I thought it was like 80 milliseconds at like, and I'm being.
No,
mean.
it's really 110. I could have shown you the thing because
Okay.
don't forget
No, I believe
here,
you.
because here you see this, you're not counting this. If you count this, like, and it gives you an extra 40 milliseconds on top of it. So it was really like 110, the LVAT 110. Yeah, go next.
Measuring LVAT, I think, and of its own is going to be trying to get somebody to actually agree with you, whether it's at the beginning of the stem, middle of the stem, end of the stem.
This case was done like last week by my colleague. I just wanted to show it for one thing. It's a guy with frequent PVCs, AV block, right bundle branch block. I just wanted to show the utility of pacing from the anode to know if the anode is in or not. So go next. Just as you're asking, this is the setup we have in the CatLab. It's the Census vibe. I work 6 lead, like I put AVL on top, AVL and AVR next to each other, 2 and 3, V1, V6. I find that if I'm seeing all these leads live, I'm working, is all the stuff that you need to look at basically. And you can do all the measurements. You're on 25, you can go to 100, you can make all the measurements and stuff. It's included in all the CatLab packages of what they receive. So it's not a big deal. So this one, the LVAT 64 milliseconds, and go next. So there's this paper in Heart Rhythm. I don't know if some of you read this, that if you're in to the B here and the anode is touching, you can actually capture from the anode and you can do unipolar ring pacing to know if it's in or not, instead of contrast measurement, for example. Go next. So for example, here when the case was done and he was like final position, he was going to stop just to test if the anode is in or not, or he was doing the ring pacing unipolar, and essentially the morphology that you get was the initial morphology that you were starting with to go in is what it's looking like when you pace from the ring in unipolar. I find it useful to know if the anode is in or not. I wasn't doing that at the beginning. We were using a bit of contrast injection, but nowadays, instead of injecting contrast, I just do one test in the ring uni, and at the end I document if the ring is in or not in, based on whether it's capturing.
I do this
I don't
every
know.
time. I do this every time because if the ring has a nice threshold to it, and I even measure the threshold of the ring. If it has a good threshold, I think it's, and I'm not perforated, I think it's actually a really great implant. And
Does anybody else use the ring testing to know if it's
I love
under or
doing
not?
this to compare the tip versus ring morphology. It somehow
Yeah.
makes me feel better all the time.
Yeah.
That's the same thing.
and you also
next.
measure the VA, right? You can measure VA interval from the tip to the ring, right? So
Yeah.
ring should be longer than the tip because if you're hitting the left bundle, right? So that's the other way to look at it.
Yeah. Go next.
So sorry, I never thought about this until now, but I wonder if the impedance from the ring also tells you if you're in or not.
In that paper, they looked at the impedance. They looked at, as you're transitioning, if you pull up that paper, they looked at ring threshold and ring impedance. But in the end, I don't know like how useful it is because the changes are so small. You'll see that. So they use it instead of contrast injection. So like we're barely using contrast injection anymore. I almost don't do it anymore in the cases. I don't know. Is anybody stopped doing contrast injections or everybody's still documenting? Yeah, you also stopped, huh? Yeah.
I stopped as well.
Maybe 20% of patients just for fun.
Yeah. I'm kind of using this as the analogy instead of the contrast injection.
The stickiness of the contrast starts to get annoying after.
Yeah, I know, it's super annoying, especially if you're gonna do manipulation after. I know.
I always ask the
this-
fellows, and what's next step? And they say contrast. So I said, okay, fine, let's do contrast. Fellows love the contrast.
This is the last one. As a patient who had a TAVI and post-TAVI left bundle intermittent complete heart block TVP is in place. So go next. So we put in the left bundle branch area pacing, like it looked like a mid kind of location, and LVAT like 75 milliseconds, and then it's nice and monophasic in AVL, but no R wave in V1. Dr. Philippon, would you advance it more?
Still depend on the injury current and you know the impedance, certainly. But you have a little R
The
prime in
impedance was
V1.
about like
You have
550.
Yeah, you have a little R prime in V1 though. I don't think the first part is the real W that you're going to start with on the right side. You're not on the right side. Your LVAT is not that bad. You have a little isoelectric segment in V6. It's a tough call. It's a tough call. I think it depends on what you see on imaging, how stable is the lead, what the threshold, impedance.
Go next. You put the
I've been
V1
burned a lot doing a couple of more turns.
Yeah, you put the V1 2 interspaces lower, and this is what you get in V1.
Yeah, it's nice.
What do you think? The reason why I did this is I saw some guy from Czech Republic show a case, like a very narrow QRS, like in V4 like this, and showing that the V1 in the standard position was showing no R prime. And when he placed it lower, he was getting an R prime. And he was like, oh, maybe that could be a reason. And there's 2 publications after regarding the presence or absence of R prime in V1. They're reporting it as being 5% of cases, but there's like 2 ways of exposing whether or not an R prime is present in V1. One of them is pacing at lower outputs, and then the R prime could be present. That's the one from Ponusami. Probably you were referring to that. Someone was referring to that earlier. And there's another one for like, from the Mastresky, who was saying that it's you do a train with like a PAC and a PVC, like a premature one, to see if you see the R prime, but I don't think anybody does that. But I think the position of V1 is useful also. And I think it's more than 5%. Honestly, like having done now, like around 40 cases, I think it's more than 5% that you don't have a big R prime in the standard V1 position. Maybe more like 15%, I don't know. Go next. Yeah, so in this patient, when I set up to do the cases now, I'm putting the V1 low. I just wanted to show, this one was with a Biotronic. We have back order on the 3830 lead. I put it with the Biotronic lead. You see V2 is here, V1 is over here. But if V1 was in the standard position, it would be up here. And I'm thinking like, if I really want to know if I'm going away from the septum, is it really like in some cases, depending on the anatomy of the patient, maybe the location in V1 is the place to be here. I don't know. It depends on the patient's anatomy. The septal relationship to V1 has a lot to do with whether or not an R prime is going to be present there. Go next. Yeah, this is my last slide. I was just going to show it here too. Like in RAO, like 17, the TVP was in place. I had placed it here. So during the case, I knew there was an R prime because I positioned the V1 low. The post-op ECG, when I was finished, I saw in CVICU, there was no R prime on it. And I said, okay, I positioned it lower. So just my last point of, like you said, also in the hybrid lab, if they put it super high and you have no R prime, like V1, the location of V1 is really important.
So you're putting it at the 6 intercostal space?
I'm putting it like at the level of V3, at the height of V3.
On the other
Huh.
side.
Yeah.
Yep.
Although in some patients, there's no difference. I tested it out in about 10 to 12 patients. In some patients, there's no difference. But in some cases like this one, there's a difference. And if you're like obsessing the getting an R prime and you're ending up perforating, I was thinking might as well put it low and see. And I don't know, I've seen a signal towards in some patients, it's not in everybody, but in some anatomies, depending if you're basal. The other hint I find from the ones that were like that, can you go back 2 slides on the ECG? If you see a very rapid transition to a V2 that's positive and you have nothing, go back 1. And V1 looks like this, and you have a V2 that looks like that, probably you're okay. You're on the left. I think you're deep in. If the V2 is already this positive.
Yeah, it almost looks like the transition for like a septal pathway, you know.
This is like basal, but mid septum.
Yeah. Cool.
Yes, that's all I was going to show in terms of.
Those are fantastic cases, Vartan. Honestly, constantly learning. Those are really great. Thanks for presenting.
So quick question, Vartan. Are you routinely putting the ECG leads lower now, or are you?
Yeah, but the last 10 cases, I've been putting it like this. Been putting the V1 lower. I feel like there's no downside to it. The other thing I've been thinking is whether I should leave it there and maybe put V3 or V4, which is kind of useless leads during the case, and put it here to have 2 there, 2 different ones to kind of see, so that in case it's a case, you know. So I think the combination of looking at like V2, V1, and maybe a standard V1 is probably the place. One of them needs to have an R prime, or going to have an R prime, I guess, but it's not always the same for every patient, especially older patients with kyphosis and stuff like that.
Or COPD.
Yeah,
It's so
COPD,
interesting
lower
for
heart, stuff like that. Yeah.
For Brugada, we go up. For this, we're going down. It doesn't make any sense. What's going on? Where's the right ventricle?
That's why EP seems complicated. We always change our mind. So nobody understands what we do, right?
That's really cool. I've never thought of moving V1 before. That's really nice.
Yeah.
You know, Vartan, I've been doing the opposite. I've been trying to go higher sometimes to put the lead on top to see if I get the right bundle. I've never thought of going lower.
You know, if you have some cases already that you know are very narrow QRS, and you have a rapid transition in V2 like that, and the patient's being followed in outpatient clinic, just do an ECG like that and see. I want to put together if there's a number of cases to maybe publish it, but I spoke to the guy who showed it in Czech Republic, and he has like a few cases too. So, but certainly I didn't see any cases that it was like worse. It's, if anything, a little bit more.
It's almost worth doing high, medium, low, and just seeing like for like 10 cases or something. What
I know, because like V4, V3 are useless precordial leads. If you have them on the right side and like at different heights, maybe it's going to be more useful than because that's what you're looking at, you know. I don't know.
Right. Great. Merdad,
Go lower.
I'm shocked.
I am also shocked because I've been working on putting these damn leads higher up as like almost into the patient's neck at some points. Okay, thanks. So I've got one case, just to a couple of cases to show. This is a 73-year-old who was referred for left bundle pacing consideration. He had non-ischemic cardiomyopathy, EF was 30-40%. Had a DDD pacemaker, pacing dependent, got a CRT upgrade. At the time of the CRT upgrade, his EF was around 30%, goes up to about 38%, but then 4 months and follow-up, the LV lead is non-functional with a capture threshold of 6 at 1 millisecond. And if we go to the next slide, I think I just put down the timeline, and he's symptomatic NYHA functional class 3. The first one on the left-hand side is just showing the echo. EF is probably a little bit worse than what they're calling. And the timeline is really within 5 months of the CRT upgrade. Unfortunate part is that the capture threshold on the LV lead that was put in place was basically non-existent. At the time of the placement from the operator's note, the capture threshold was 3.5, I think, at 1. And then in follow-up in device clinic, it was at 6 and 1. There was no capture, not even diaphragm, unfortunately, or fortunately. Next slide. So just put this on just to show where they had put the LV lead. This was the images from the time of the lead placement. They've gone and shot one of the anterolateral branches. They seem to have selected the posterior branch, and they've left their quadrupolar LV lead there with the RA and RV that was from previous surgery in 2018. Next slide. This is the ECG of the CRT lead at 3.75 at 1 millisecond. This is immediately post-op. You know, not terrible. We see these with the CRT, but you know, once you've seen Vartan's cases, this is like, what the hell is this crappy CRT lead that you guys have put in? So next, now that it's not capturing and the patient was purely RV paced, QRS was around 200 milliseconds. Yeah, next slide. Sorry, we went ahead, we pulled out the LV lead to do some plasty on top to open things up. And put in the CRT, and this is the left bundle lead. It's a little bit on the higher side of things, and you can see that from the ECG, I think, afterwards. But that was the final position that I put in the lead, and that's the CS lead on the left-hand side that's been pulled out afterwards. Next slide, I think you'll see the ECGs. So this was the bipolar pacing from the left bundle pacing from up there. At this point, you know, as I said, I haven't tried measuring LVATs on the anesthesia monitor on ours, but visually it looked fine, and you know, we had the right bundle looking pattern on V1. On unipolar pacing in the lab, it looked much better, so I went ahead and changed it to unipolar pacing. On the next ECG, you'll see unipolar pacing from the LV tip, and you get even narrower capture. And this made me think about, you know, whether I would just have to program every single left bundle pacing lead that I put in, instead of, you know, the true bipolar from the tip to ring, to just unipolar pacing. The capture thresholds were pretty good as well. I think this is at around 1, if I remember correctly. It's either 0.75 or 1 on the Medtronic device.
That's almost, I mean,
sorry?
such a striking change that almost certainly in unipolar, you're now getting the left, you know, anterior fascicle there, right? I mean,
yeah, I think so.
So the other is left septal pacing, and this is, you know, through whatever virtual electrode or whatever.
Yeah, I think whatever type of
it's sort of the LVAT's tighter and everything.
But it for me, it was more of the importance of like rechecking these immediately afterwards in the day unit, because most of the time I do the programming in the operating room, and then they kind of go off to be seen in a month or a month and a half in the device clinic. But I think it's made it a little bit. Sorry, those are all me. And that was it. Nothing.
I agree with Klaus. It's beautiful. This unipolar, it like clearly stepped out. Look at this isoelectric interval that you don't see on the bipolar. Look here, you know, this slurring is not, you know, clearly is taking the myocardium or the septum, right, part of it. Whereas here it's quite nice. It really steps out.
I always look at V1, you know, that sort of slurred start, that's never a good.
Yeah.
Go somewhere else when I see that, and usually you can, you know, if you try it, or often you can get this result. So I think this is sort of almost proof that you're capturing 2 different tissues. It's like having 2 thresholds, except it's unipolar and bipolar.
Yeah,
I guess the anode was in the septum, right?
Yes.
Yeah.
So
actually, I noticed it. I've been programming most of the last cases also on unipolar, but when the anode is in, sometimes you're finished the case, you tested it, everything's good. You connect the generator because the generator's in bipolar, and then you see what was this? Like it looks different right away, and it's the anodal stimulation. But I looked, like the total QRS duration is almost the same in most of the cases. Is just the beginning of the activation looks kind of different when the anodal stimulation. It always looks better in unipolar, I find.
I think you have to be, yeah, I think you have to be careful because when you're doing your threshold, so when I finish the unipolar testing, I do bipolar testing and I, do the threshold and I come down super slowly, every 1 or 2 beats by 0.1. And you can see that step out on the current of injury on your left bundle pacing EGM. And you can see that typically on bipolar, that threshold, that change from non-selective to selective will occur around 2.5 volts. And so I think you need to make sure that you're programmed more than 2.5 volts if you're going to be programming bipolar in your final parameters, to be able to use that anode. You see what I'm saying?
Yeah.
But I find even when there's the anodal stimulation, is it really better? I find that sometimes yes, sometimes no. Sometimes it looks, the total QRS duration I find doesn't change that much. It's just the beginning of the QRS that's different.
I think here it changed beautifully, so I guess it just
I
depends
hear it's for
how
a
much-
different reason. It's not because of anodal. It's just you're getting more, I always say more reach basically with a unipolar lead.
That's true.
You're just basically stimulating something further away. You're not right on it, but who cares in the end? I mean, if you get that kind of, you're getting, as I say, they call it the virtual electrode.
It's interesting. There's a
Yep.
there's a paper I reviewed recently. I guess it's going to be published probably, but they actually looked at what they call biceptal pacing using. So if you're pacing unipolar, most of my patients I program unipolar because I think it's often better results, and I'm sure I'm pacing with the helix, and that's what I want. And what they did is in the same patient, when they were screwing the lead, in some patients they were not able to get the nicest QRS with unipolar pacing, but when the ring is deep in the septum and you pace bipolar, you can actually capture kind of both sides of and a backward to the right bundle and have a narrower QRS. That's kind of a new concept of, you're not selective, non-selective, you're biceptal, and you recruit more of the conduction system that's left in the patient. I found it very interesting because most of the time, I program my patients unipolar, and I was thinking, Barton, what's the advantage of doing bipolar? Why would you use bipolar? Because some are saying that you're going to lose capture maybe if the screw advance, or you can have a problem if you stay in unipolar. But I've not seen that. But I think that's an interesting discussion. Should we program unipolar or bipolar, or just look at EKGs for all patients and just select the best for each? And I found that concept of kind of biceptal pacing with narrower QRS than pure unipolar was interesting.
I have to tell you, Francois, I do it in every patient. After I program, I do unipolar. And what does it look like in bipolar? I try all different AV intervals. And I think most of the time, it doesn't really change much. But when it does, it's quite clear, so I still do it on every patient just to see. But
I would agree with you. It's truly the exception. They must have published the one case because, we do it routinely as well. And once in a blue moon, it makes a big difference, but almost always
it always, for me, it looks better in unipolar almost always. I agree with Klaus, but barely. Okay, Merdad, you're on to next case.
Okay.
It is interesting though, like if you were initially screwing, it does seem a bit too high. But when you keep going, you get a beautiful morphology.
So it definitely, I left the X-ray because I think I even send this ECG to Dr. Static as well. I thought it was actually on the higher side of things as well. But the ECG was so good that I was like, you know what? I'm gonna leave it. If you even look at the ECG, inferiorly, it's all positive, AVL and AVR I think they were both negative, if I'm not mistaken. So it's it probably is a little bit higher up on the septum rather than the mid portion of the septum.
Right.
But I was like, you know what, I'm gonna go with the ECG. If it looks good, I left it. Now, long term, whether it's gonna creep its way out somewhere, I don't know. But we'll see.
Great.
Would
Just
anybody
incidentally,
else
all
this-
those T-wave changes, do people see those all the time? Some kind of T-wave memory, you're changing depolarization dramatically. If you just go back, you see these.
Initially, sometimes
Yeah, fairly quite dramatic often, eh?
Yeah.
It'd be interesting to do them all again a week later.
I think the ones with very abnormal, you'll see them a lot, at least with the left bundle ones and the ones that are pacing dependent. I find that have been, paced for quite some time.
Some
but I
kind
don't
of T-wave memory issue, yeah. I always like throwing out those terms. Nobody ever knows what T-wave memory, at least I've never been able to understand what it is, but it isn't, certainly some seems to be real.
Yeah. This was a 60-year-old lady with a complete heart block presented to the hospital, basically with progressive shortness of breath. We can go to the next one. We had some conduction resumption when we saw her. Put in an atrial read just to quickly check what the winky back was, and she was winky backing even before we put in the atrial read. So next slide, we went ahead and put in the lead. This is more of a septal kind of capture. And at this point, again, I was debating, do I push it in a little bit more, don't push it in a little bit more? It feels like you need one more screw, but then I always get worried about puncturing through, especially in normal septum. And I can't remember if I put in the septogram on this one or not. It might be next slide.
Do you think, just looking at your EKG,
Yep.
oh
yes,
do you think you were screwing in the left posterior hemibranch? Because you kind of have, your V6, you have an S wave. It's like a left anterior hemi block.
Because I think
so,
the ECG that Francois is
I
talking
add it often that, sometimes, that your V6, you have an S wave and you have kind of a left axis deviation. It's like we just screw more in one of the fascicle than the other. Probably the posterior one in this case, because lead 2 and 3 are negative and you have an S wave in V6. So you're probably screwing in the hemibranch there.
Yeah. But it's a very nice result. Like AVL, it's like, it looks like there's very nice.
Beautiful.
But I think I wanted to show it because on bipolar, you get the septal pacing or whether you get the recruitment on both sides or whether you're actually just getting the one side. And then you go to unipolar, you get that nice right bundle looking thing with, again, LVAT didn't change much between the two. But it was more, aesthetic.
Let's go back one more time.
Yeah.
Did you do unipolar from the proximal?
Sorry, say that again.
Do you do unipolar from the proximal?
So I did from the ring electrodes during the EP procedure. You lose the right bundle component, and it looked more a left bundle-y looking thing. Not as narrow. These ECGs are post operative.
Yeah, you can't do those. You can't do that after. Yeah,
exactly. It would have been nice to be able to do it, but yeah.
I have a few slides on
the
that.
most common thing we see it is when you connect the generator. Like you have this morphology before you connect the generator to come out. You connect it up and you get the one you have there. It's like common, yeah.
I think what's really nice about this is the wider kind of R wave here. It kind of steps out, and I think that's what makes it more selective to the left bundle. And there's a criteria which I have a few slides on a little bit later, and it's looking at the essentially the R wave peak time or the LVAT or whatever in V6 and comparing it to V1. I'll show you in the next slides because it's really a nice look, and I think that's what you have right here. It's a perfect example.
Less than 40 milliseconds or 30 milliseconds more than 40. Yeah.
I love when the ring is like completely through. This is a great, like, you're going to get a good result, I think,
Yeah. So, my only hesitation with these is always going to be like, lead longevity and how they're going to do kind of long term, but it looks nice. So we just, kept a video of it. But yeah. And this
Right.
was the same case, obviously.
Great. I think you have one more here.
Oh my. So I don't know how many 88-year-olds you guys are doing left bundle on, but I got referred this for on my list for a CRT pacemaker and a patient with bradycardia, EF of 35%, and apparently fairly functional. You see him, he's quite scrawny, and I think instead of we teeter-totter between if somebody does need a CRT, whether you actually truly give him a CRT versus you try a left bundle. Because he was elderly and quite skinny, I wanted to reduce lead bulk and the device size potentially. So decided to do a left bundle on him, and we can skip these ones. That's the final position of the lead left bundle. So instead of having 2 wires in his permanent AFib, he ends up with this, and then I think the ECGs are immediately after. So this is his baseline ECG. I think as Vartan was mentioning, some left bundle not super wide for a left bundle, but about 130, 140 milliseconds or so. And then the next one is the final results. This is unipolar pacing again. I teeter-tottered. I should have probably screwed it in one more screw or something like that, but it was 88. I kind of chickened out a little bit at the last minute, and I always have this issue. I'm like, do I screw in one more? I've had a few cases I screw in, the lead just goes to the other side, and I always kick myself afterwards. So left it at this. I tried with unipolar, obviously, as well as bipolar. I couldn't get anything better than that. So left it again. LVAT time was depending on where you pick your beginning of the pacing spike, end of the pacing spike is not terrible. It's around 80 milliseconds or so. Hopefully he'll have good results. This is recent, so I don't know what his EF has done. So we'll see him in follow-up in the device clinic.
Very nice. Very nice.
I hope that's the last one, I think.
It is. No, it's fantastic. I think you have one more, but maybe I'll move on because I think these are all great. We'll keep them for the next time. Klaus, do you remember?
Yeah, this is really just for fun because, we don't do EP studies on patients who have heart block. So this is 78-year-old lady, permanent AF, has been in AF for years, intermittent dizziness. And this is her ECG with these funny, I would say fib with these funny sort of pairs of and then when I put and again, this is put in the left bundle lead in the, we have a portable, so we do ours in the OR, but we have a portable recording system, which I can tell you, it's great. You can do them anywhere. It's a pain though, trying to get the noise and there's cables everywhere. It's great we have it, but it's trouble. So the next one is the intracardiac electrogram. So the middle one is, it says HIS-D, so the center one. So this is the left bundle, the 3830 lead in the HIS position. Okay, and I'm still old-fashioned. I try to find the HIS in each case because I think it helps me positioning I know exactly where I'm starting, and then I can move from there. So this is just a lovely, infrahisian block in an AF patient where you get these irregular HIS signals. And this is somebody, with this sort of ugly looking ECG. So it doesn't preclude you from getting a good result because that's a fairly, it's just a nice picture, of which we don't see very often. And the next one is the paced one.
Beautiful.
A nice result, surprisingly. First, I didn't think we were going to get, I agree with you, people who have atypical, IVCDs and odd looking, notched you don't usually, but obviously this person probably had, you know, fairly proximal disease as their main problem. And you end up with again, these very bizarre T waves. I'll have to next time throw up the 3-month follow-up one, because I suspect those will normalize, but a very short stint LVAT, very narrow QRS. So it's just a nice, it was really, the first one was the point, not the, just for fun, not
It's
for.
amazing you can find the hiss. So on a normal patient, we have a hard time finding hisses sometimes.
Well, yeah, I just find, as I say, if I have a hard case and I haven't found the hiss at the beginning, I've tried a bunch of spots, I often go back to the hiss and I try and find, and I often then you know, if you get the exact spot, you just go 1.5 centimeters distal and all of a sudden, boom, you're there. Or to be frank, sometimes I just pace the hiss every once in a while. I still do that, but okay, so that was then. Then the next one, this is a very interesting case. 56-year-old female had in March of this year, not at our institution, presented to another institution that doesn't do ICDs, they do pacemakers, and had syncope with intermittent heart block, normal ejection fraction, had a pacemaker put in March 2022. I apologize on behalf of my ECG department, but I don't know, this was the ECG before, pretty fuzzy thing, but you get the idea. Paced, not terribly wide, 150 millisecond QRS. Then the patient presented with a cardiac arrest at the very end of October. And at the post-arrest, fortunately, had to be shocked at the site. Fortunately, had a good neurologic recovery and an ejection fraction done in the other institution was now 30 to 35. So they were sent to us for an ICD. Now, obviously raises the question as to what's going on, you know, what's the diagnosis that, you know, do they have sarcoid, do they have, but